by asking you, what if clinic didn't run on crisis mode, but on orderly flow? What if every patient didn't feel like a full-time job? What if we could meet the ever-increasing standard of care in a sustainable and rewarding way, and in so doing reduce burnout and stop losing PCPs? So that's what I believe is the promise of the Clinic of the Future. By way of introduction, you guys know me, but I just put a couple of career highlights down here that essentially are kind of showing that I've been around the block a few times in healthcare, as I think a lot of us have. I've seen a lot of things. Medical director of various things, including medical home, Go Health, and previously Zoom Care, and then most recently chief medical officer out at Mount Hood. But I did step away from that last year, in which I worked closely with a lot of the folks here. Stepped away from that to start my own healthcare consulting company, Novella Insights, and that's actually what's given me the sort of brain space and capacity to develop this Clinic of the Future concept that I'm excited to share with you today. This is sort of premised on the idea that Clinic of the Future is going to be a key part of where we go, I think, and that this moment is really one of tremendous change, disruption, frankly, challenges. I think we all know that. But I'm really pushing myself to say, where's the opportunity in that? How can we dig into all of that sort of difficulty or negative aspect and try to find the opportunity to rebuild maybe more thoughtfully, proactively, holistically, something that works for us and our patients. So first though, a little background. So you may know this, that our current model of delivering visits in clinic really dates back decades, many decades, to after World War II. Since then, though, medical complexity has really exploded, and I think we all can feel that sort of deep in our bones. We have been grafting on tweaks and modifications onto the same basic model until it kind of looks like this house, pretty much shaky foundation, cracking, almost ready to fall over. And you know what these things are. It's another dot phrase coming up in the EMR, or a button, or a different patient satisfaction survey, a new guideline that isn't as clear as we would wish and requires a lot more discussion with patients to sort out based on individual preferences, et cetera. And I posit that stress and burnout kind of grow with each tweak, and that it's time to really redo this whole foundation and rebuild. Now, funny enough, of course, I think it's obligatory in a future-oriented presentation to say how you used AI, so I used AI to generate this image. So does this resonate? Do people feel like you kind of know what I'm talking about? I'm seeing nods, lots of nods, wonderful. So
all the HCC diagnoses.
HCC diagnoses, I know, and I used to push those as medical home director, so conflicted feelings about that, right? Absolutely. So I would argue that change isn't just about to come or on the horizon, but that change is inevitable, that it's already here. I think the question is not, will it happen, but who will shape it and be in charge of it? I think 5 years from now, care is going to look very different because we just can't keep doing business as usual. And we're going to get into some of those reasons, but of course you're intimately familiar with a lot of them. But it's really our response to change that kind of determines whether we're going to thrive in a new era or crumple. I don't think we have the luxury, though, of sitting on the sidelines, because if we kind of sit back and say, someone else will manage this, I'll wait to see if somebody else has a good idea, I think it will happen to us, and I think it will be hodgepodge, and it will be one Band-Aid at a time. And based on a conference I just went to in Chicago that was all about AI and the future and everything, there's a lot of vendors out there, and they all have an idea for their little corner of the world where they see a financial opportunity. What that may look like for us is sitting behind a computer with a little solution bolted on over here to that shaky foundation house, and a little one over here and something over here. They all make sense in the silos in which those decisions were made, but holistically to practice in that environment is going to be tough. So I think Clinic of the Future gives us a roadmap to redesign care. And then I put at the bottom there the basic formula. So a trusted multidisciplinary team using a personalized cookbook to deliver care in a flow, not discrete packets that we currently call visits, supported and enabled by tech. So let us go ahead and review our agenda for today, which is basically Clinic of the Past, little spin into the past and how we got to where we are now. Clinic of the Future, this is going to be my sort of presentation of a concept on that, as well as possibly some other either objections or alternatives, the sort of to be sure paragraph in an editorial, if you will. And then talk about what steps we can take now. And before I dive in, I'll just also say this is entirely my own concept, and I'm not speaking for Legacy, even though I'm speaking here at Legacy and still an employee. And if anybody does have thoughts or input about this, let's meet up, coffee's on me, let's talk about redesigning care for the future. So super interested in hearing everyone's kind of input and opinions. And I don't also have any conflicts of interest or disclosures. So without further ado, we're gonna go back to 1995 and we're gonna meet a typical patient at that time. So here's Ms. Jones. She's a 49-year-old woman, has hypertension and hypothyroidism, takes the typical meds of that era for those things. She gets the typical labs. It's pretty simple, yearly BNP and TSH, lipids every 5 years. Those were the guidelines at that time. And basically she comes in kind of as instructed. She gets the pap and mammo yearly because we didn't have arguments about frequencies at that time. It was pretty straightforward, and then she would call if she was sick and maybe have a sick visit. So when we cared for Ms. Jones, you know, we could feel like we could finish on time. We weren't exhausted. We felt like we did a good job. She was happy with the care. We were happy. And that feeling keeps you coming back to work, which is a nice thing. So does anybody remember Ms. Jones? Did you know Ms. Jones? Maybe not 95, but
95. Maybe that was like
95. Okay, perfect. We've got a true 95er. Awesome. She was pretty nice, right? Ms. Jones was cool. Yeah.
I
Okay.
see 100 of her.
Yeah,
Well,
exactly.
I would. I'd see a patient every 15 minutes.
Right.
Like, you could do it, and you could write, because you would say hypertension,
Yep.
hypothyroidism, check BMP, TSH
Exactly.
as I'm talking to her.
It was a whole note,
It
and
was
you
a
didn't
whole
have to
note.
worry about it
My
later.
favorite note from that time was this note said, URI amox.
So many questions about that.
Right, I was saying there's some issues with that.
URI
Yeah.
amox.
That's hilarious. That might have to be a joke that goes into the next version. So exactly. So basically it was a simpler time, as you really well articulated. You know, everything was paper-based. That had frustrations, but it also imposed the speed of paper on the work. The documentation requirements were much lower. You could get away with URI and MOX. You scribble some stuff down, and basically paper didn't update itself every 3 months, you know, either. So there's that. Patients were less sick. You know, I didn't even delve into statistics about that because I think we all know that. And then, of course, we didn't have my chart messages. Nobody did their own research unless they worked at OHSU. It was years before we could dream of Dr. Google and, you know, kind of being your own doctor and that sort of thing. So it wasn't perfect, but it was easier, partly also because people trusted us, and also kind of overall standards of behavior perhaps were just a little more intact than, you know, we currently find ourselves. So that was the past. And then here's a concept of clinic of today, kind of going here for like futuristic med spa meets Starbucks mobile, you know, ordering, something like that. And my argument is that it's really overwhelmingly complex, and that the requirements for basic functioning for ourselves, for the staff, for the patients are so much higher in so many different ways, and that really that causes burnout and stress for us, and it causes dissatisfaction for the patients. So we're gonna meet Ms. Jones of today. I think you know her already. Just gonna say a couple caveats. I had fun writing this. Maybe it's a little exaggerated, maybe it's not. You be the judge. You might have seen her in the morning. You seem like you already saw her. Yeah, exactly.
That's my 2 p.m.
Okay, there you go. And then also, you know, patients aren't the enemy. We're all patients. We can all have a bad day. So I certainly don't want to overly blame them, but like too many encounters like this can certainly be a challenge. So here she is, still a 49-year-old woman, still hypertension and hypothyroidism, but now obesity with a BMI of 32, hasn't been seen in 2 years. So she comes in for a PAP and a checkup to talk about some things. Sort of the dreaded some things. She's been saving them up, you know, for this visit. And so what are they? It's my stomach hurts. Really, it's been for years, but it's worse now, you know, so prompting perhaps part of the reason to come. She thinks she has adult ADD. She's been taking her son's stimulant meds here and there, and it's working. So she'd like her own diagnosis and prescription, you know, please and thank you, right? Because that makes sense. And she can't lose weight. That's obviously a challenge. She's wondering about Ozempic. Let's have that conversation. And then, of course, periods all over the place. Maybe it's all perimenopause. So she comes in for this for her PAP visit. And then, of course, while rooming, the MA astutely, you know, does what they're supposed to do and gives the PHQ-2, which reflexes to a 9, and she has a score of 19, and she has positive suicidal ideation. So we've got her agenda of the things she's been saving up, our healthcare maintenance agenda, and then also an acute problem of suicidal ideation. And then, of course, we know that once we get into the room, we're going to be dealing with best practice advisories too, which, of course, always pop up right at the time that we're doing something else to remind us to do extra stuff for her. It's going to be still the same mammogram, but now colon cancer screening because our age has been lowered. So, you know, that's one of those aspects of complexity, as well as HIV and Hep C. So obviously things that we weren't thinking about in 1995. So what does the doctor do? So, she does her best. That's the bottom line. She does her best. Also used AI to create this image of a somewhat
It does not look very
frustrated, little bit of a bummed out
Yeah.
PCP here. So
What did you tell AI to give you?
Oh, I gave it multiple prompts.
A
I
really
had to
sad
change
doctor.
it, a little frustrated, sad, a little older, multiple things. Prompt engineering, So anyway, of course, as you guys know, she's got to think about what is going to harm the patient the soonest. That's going to be the SI. So we have to pivot this pap smear to really more of a depression and suicidal ideation investigation here. Fortunately, she has more resources. So she's got a BHC in clinic, behavioral health consultant that she can hand off to make a safety plan. She finds out that the SI is passive. There's no active plan. There's no firearms in the home. So these are good things. They do shared medical decision making to hold off on starting an SSRI right now because this is a new thing. And she gives a handout on, depression management and whatnot on the after visit summary. She kind of tries to address the ADD as part of this mental health picture by saying, we can't really diagnose that yet if we have uncontrolled depression, but let's hold off. And no, I'm not going to be drawn into writing you your own Adderall on this first visit. So there's that. And then, of course, as you guys know, the abdominal pain, right? So how many times have we asked the patient a million questions, all the right things about the quality of the radiation, alleviating all that stuff, while frantically going through the electronic record, trying to figure out what has been done for this. And indeed, the doc finds out that everything has been done for this already. So although the patient comes in saying, my stomach hurts, in actuality, there's been a right upper quadrant ultrasound, there's been a CT scan, there's been labs, celiac testing, and a GI referral that wasn't followed through. Okay? So, kind of typical stuff. So the doctor kind of scrambles through this. She does a trial of a PPI. She tries to redo the referral to GI. She orders a whole bunch of labs, not just that BMP and TSH, but folding in all of those other conditions. So thinking about the A1C for the possible GLP-1 coverage, going into fatigue and depression workup, abdominal pain workup. And she doesn't have time to argue about whether we should check FSH and LH, so she just does it because perimenopause and she's ordering blood already and let's not have two pokes, so she does that. Then she throws in some health maintenance and then tries to address further things at the follow-up visit, including, of course, do the pap smear, which really has to be done in person and was one of the patient's major reasons for coming. And I won't kind of go down through every bullet point on there, but you can see it's a lot. So that's what the doctor does. And then what does she do? Womp womp. Sad trombone, sends a My Health message with a rash picture, but blurry, of course, right? For something that couldn't be looked at the visit, and then complains that, it's not all getting done in one visit and it's expensive. And we get it, right? It is expensive. And yet also the doc was clearly, of course, sort of doing her best. And this really almost could have been 3 visits, basically by the kind of current standard of care. So Ms. Jones of today, this morning, this afternoon, yesterday, yeah? Yeah. How does it feel?
Most of them, yeah.
What was that?
That's
all of
Annie's
my
entire
vision,
panel.
Yeah. Entire panel. It's hard. It's really hard. Yeah, absolutely. Alrighty. Well, so there's another version of this talk in which each one of these things is a whole slide. But I'm going to spare you guys that and just kind of spin through, because I think this audience is very, very familiar, how things are more difficult today. And then this is going to inform how we want to build for Clinic of Tomorrow. So again, sicker patients, drug use, we didn't uncover illicit drugs here, but taking your son's controlled substance is kind of a gray area, perhaps one might say. More mental health stuff. Of course, it might have been going on before and we didn't know about it, but now we know and we are obviously interested and obligated to treat it. The expansion of responsibility for social drivers of health. I kind of like to joke that back in 1995, we didn't even think of like food as medicine, much less food insecurity as specifically affecting patients' health. But of course, now we have so much more consciousness of this, which is good. And we are altruists, so we want to help. But it comes at some cost because, again, these are tweaks added onto that shaky foundation. And then the explosion of knowledge, everything fragmenting into multiple guidelines, talk to your doctor about whatever, that kind of thing, individual risk assessments and personalized medicine, which is really cool, but just all takes time and sort of energy and effort and that kind of thing. And we see this in Ms. Jones asking about the GLP-1s and the menopause hormone therapy, question and all that kind of stuff. So little audience participation. Who has an idea for how many shots which I didn't go heavily into here, but have been added to the average risk adult schedule since 1995. Not that they're entirely new, but they were only recommended for certain people, and now it's just everybody needs these shots. Any sense of it? Doesn't it feel like we're giving shots
Does
mean
like
all the
Hep B,
time?
does it count as
It
3?
does. No. It counts as
Okay,
one.
okay.
Oh no,
Okay.
it counts as one. Good question.
6.
That is exactly right. It is literally 6 shots that have been added. And so just, for sort of completeness sake, pneumavax, shingles, HPV, Hep B, COVID, and RSV. So some of those
are
existed,
multiple,
but, and they're
and
series.
It's
Yeah.
series and multiples. Like I had a patient
Exactly
who
right.
had a COVID shot in
Mhm.
July, and she is due now, like 4 months. later.
Exactly. And that's also that confusion of like, what is really the right time for the COVID shot with the summer wave and stuff like that? Absolutely. We won't even get into the status of where our guidance is at in this country at this exact moment, but yes. So shots do kind of act, I think, as a microcosm, also because they affect not just us, but our MAs. So the original version of this talk was actually for an MA conference, and we went deep into the schedules and the additions, and that's extra burden on them while they're rooming, either before or after the visit too. So it affects all of us, kind of an instructive example. Then quality metrics, I hate to say it as former medical home director because I love the idea of, incentivizing outcomes of care rather than fee for service, but it's a double-edged sword. We've got so many new things since 1995. They keep expanding, they keep getting more complicated. And we saw that in her case, with the screening for Hep C, HIV, the depression even, which we didn't used to do that PHQ-9, everything, et cetera.
I
Okay.
would add to this
Yeah.
like a new layer of medicalization of life. So
Yes.
pet letters.
Completely agree.
Like
That's a
FEMLA
really good
leave
point.
for caring for a family member. It's
Mhm.
like medicalize DMV forms. I mean, just
Right.
the forms that we're
Yeah.
required to do that where things have become medicalized and a doctor
Yeah.
can get you PGE cheaper,
Exactly.
Your bill
Yeah.
paid for.
Mm-hmm.
I want a south-facing apartment, and,
Oh, yeah.
and to not
Yes.
have my unit be fumigated for cockroaches because I
Ooh.
bought my
I
own
know it.
cockroach traps, and therefore they should not fumigate since
Wow.
it's respiratory.
And you need to
irritation.
write the letter explaining all of that for medical reasons, of course.
I had a
Medical
patient
reasons.
today who's being forced to take leaves, 15 minutes of paid leave every time she pumps by her job. And I had to write a letter saying, please follow the
Pumping is
federal law.
yeah, like a
Go to my
protected
office and
activity.
Research and think what to write.
Yeah. Gosh, exactly. No, these are great examples. I knew you guys were going to have great thoughts. Absolutely. And then of course the EMR, I'm not going to keep talking about that. I love the EMR actually, and it does bring us efficiency, but of course we all know how it increases the burden. And each one of those new phrases like the chaperone and the sensitive exam and just extra stuff, or I'm the part of the patient's PCP team, it's just more things to think about. And then the out of control inbox, which, why could that be happening? Well, I would argue that at least a large part of it is, of course, if you have a tool, you're going to use it, hence email, my chart messages. But also, let's be honest, patients no longer just do what we tell them to do because we know best. No, they don't do that anymore because they're consumers, right? And so consumers think about things in a different way. They want healthcare with a side of customer service based on their preferences, their values, and stuff like that. And why is this? I think it's because other tech-enabled areas of life have shaped expectations. I'm talking about Amazon, Uber, DoorDash, where they are meeting needs almost immediately, enabled by tech, and people naturally shift those expectations onto us. I don't blame them at all. I completely get it, and sometimes I feel the same way too. But at the same time, healthcare was not designed to be delightful. I mean, mic drop right now.
I've
Just
got
kidding.
to be a pen.
Yeah.
We're on my lapel.
Exactly. But yet we have these customer service, basically surveys, that create that pressure to delight the patient by giving them maybe what they want, not exactly what they need, always a push-pull, attention, the discussion takes more time, et cetera. So, this leads to, of course, mushrooming communications. If they can email us at midnight, why not? Would like an answer by 8 a.m. with the blurry rash picture, for example. Okay.
It's not even the expectation that we answer, it's that we need to know the cognitive burden of knowing
Yeah.
that this patient has an upcoming appointment with so-and-so.
Right.
Like, okay,
Yeah.
done.
Yeah.
It's that cognitive burden
Yeah.
around knowing every single
Knowing
thought that
everything.
a patient has.
No, I
Pooped
couldn't agree
once,
more.
just wanted to let you know.
Yeah, yeah.
Exactly. Totally.
Cool.
So Here's a little joke then. When a kid says, Daddy, I want mommy, that's their version of saying, I want to speak to your supervisor. I thought that pretty much captures it. And then, of course, even beyond the four walls, this also could be a whole nother talk. It's not going to be today, but basically larger societal shifts. So really the pandemic did about 5 or 6 really difficult things to us. Rising costs, interruption of supply chain, unionization, turnover, all of those kinds of things. Loss of trust in experts, in vaccines, all of that kind of makes our lives harder. And then behavioral changes and violence, let's be honest. So there are these things. And then we have this sort of looming shortage of physicians, shortage of medical knowledge workers, primary care deserts, and poor access. And we saw this playing into her care. And then there's sort of AI coming down the tracks at us like at 90 miles an hour. And it's like, what are we going to do? Are we going to jump into the driver's seat? Or are we just going to get out of the way and try to dodge, which I don't think will work forever, et cetera. A small part of this too, but it really ties back into patients as consumers, is when people are consumers, then you have fragmentation of your consumer base based on their preferences, personalities, styles. And so you have things like the younger patients who are the digital natives that literally want all the care on their phone. They would just text you stuff probably like all day long, maybe bowel habits or what have you, and never want to come in. And if they could get their PAP over text, they would prefer that as well, right? I mean, yeah, maybe not limited to to those digital natives, exactly. And then we have the older folks who need more care, and we have things like video visits and the portal to give care, but maybe then, not all of them, but some of them struggle to access that. And so we have tools, but now, like you said, kind of cognitive burden of like which tools are appropriate for which part of the population. And again, it used to just be a lot simpler, which kind of leads to this joke, which is, how do you confuse this new generation? Lock them in a house with a rotary phone, analog watch, a TV with no remote, a dial-up computer, a stick shift car, and leave the instructions in cursive. We are going to talk about Clinic of the Future. And so this is like just a bigger slide basically that breaks out that little formula that I put on the other one. The team, the personalized cookbook, care as a flow, not single visits, and supported by tech. And really this is about, in a way, kind of breaking the visit, breaking the clinic, breaking the dependence on the one single trusted PCP. It's a lot of breaking. I mean, it's a little challenging, right? But again, challenge and opportunity, I think, going hand in hand. So we're going to meet Ms. Jones of 2035 and see how all of this plays out for her, okay? I did change the pictures for her each time, but I mean, it's still really supposed to be the same patient. I just didn't want that one poor lady to have her picture hammered all through the presentation. So we're going to say that this is the same patient, and she hasn't had care in a while, but she does kind of get the urge to get some health care, and she's feeling like it's been a long time for her PAP. So she picks up her phone, I'm assuming in 2035, we still use phones in the same way, and opens up an app called Charlie Chat Care. And this is an empathetic AI chatbot. It knows her and her medical history, and we've sorted out, HIPAA issues and whatnot, that type of thing, and data security. And it knows her personality and how to communicate with her in the most effective way. And so I kind of listed the things here, but this is what it sounds like. She, speaks or whatever she does into Charlie, and she says, I know it's been a minute since I've been to clinic. I think I'm due for my PAP, but I just feel so crappy. And then here are the things. The stomach pain I've had for years is getting worse. I keep gaining weight no matter what I do. I'm crying all the time over nothing, and my period is all over the place, and I can't concentrate. Zach's Adderall helps, but sometimes I feel like I just don't want to wake up in the morning. I think it might be perimenopause. What should I do? So we remember that this all kind of landed on the doorstep of the clinician in the last scenario, the scenario of today. So Charlie says, that sounds really rough. Tell me more. When you say sad and depressed, what does that mean? Are you thinking of harming yourself? Charlie elicits the suicidal ideation. Charlie finds out that it's passive, the same stuff. It's not of a high acuity level, but nonetheless, Charlie sends a message to the clinic BHC and alerts them that this patient is struggling. So they start texting the patient, go back and forth with text, convert to a video visit. And at that video visit, the therapist kind of goes over all of those same things that Charlie had found out. They make a safety plan. They talk about lifestyle management support, what the patient can do now to feel better and stuff like that. And the therapist says, well, let's schedule a visit with your PCP so we can talk more about maybe a diagnosis and medications. Okay, so after this, Charlie keeps on gathering info, provides education on meds and lifestyle, starts to talk about things like the weight loss meds, the pros and cons, et cetera, and then crucially, provides expectations for the visit. So the patient expresses some things like, I really hope I can get this all done in one visit because I hate going to the doctor. And Charlie says, yeah, I totally get that. And this visit is going to focus on mental health stuff, and we're going to keep talking, and thank you so much for, building this bridge and that kind of thing. And we'll be laying the groundwork to deal with mental health and maybe kind of addressing some of these other things, but let's not expect that this is going to be a magic wand solving everything in one go. So the patient kind of reluctantly goes, okay, I get it, that's reasonable. So then she comes into the visit, but meanwhile, Emily, the EMR-based AI bot for us, has been prepping the visit. And this is what changes it from that sort of monster or even toxic visit that it was before into something that is at least manageable. So Emily goes over everything. Emily has access to things like pharmacy fills, so it can construct an actual med list, knowing what the patient is filling and that sort of thing, and dosages, cutting down a lot of that back and forth. And instead of the doctor kind of frantically digging through the chart, for example, for the abdominal pain, Emily is able to do all of that prep work and figure out what's been done. So she spits out a plan here, and first thing, of course, again, depression and SI, and she says this is new. Maybe consider an SSRI. This is her recommendation to the doc, and the doc can use her own judgment, of course. For the abdominal pain, she goes through all of that workup, recommends that we complete the GI referral, spits out a diagnosis, or I should say a differential by percentage. So she says things like, 40% chance this is GERD or gastritis, 30% chance it's constipation, 20% it's IBS or functional, less than 3% chance of anything really serious going on is the etiology of the abdominal pain. So recommend basically hold off on imaging because some of that's been done, refresh the labs and trial a PPI. And this is that AI real-time clinical decision support that we sort of have if we back out of the EMR and go into up-to-date or open evidence really being obviously the AI-powered one. But I think in Clinic of the Future, we'll have this all integrated so that we get this real-time help. Or this is even visit prep. And then for obesity and perimenopause, again, let's check some basic labs, let's hold off on meds, let's continue the conversation, etc. Patient comes in, her blood pressure is elevated, that's a new thing. So rather than jumping on it with a label and a med, we're gonna say, okay, let's have a connected health blood pressure cuff that you can use at home that is going to upload the readings into the EMR, where Emily's gonna read those readings and flag if things are consistently high. So we're gonna be the version of what we do now of take this cuff home or get a cuff that I'm prescribing you and keep a log and review it next time. Instead, we're going to have proactive reviewing of those numbers. Okay. Meanwhile, this is complicated because care is still complicated. This, Clinic of the Future isn't going to make the care simpler necessarily, but easier to deal with. So we have Charlie reaching out for the health maintenance of the mammogram and colonoscopy. Gather some information about possible ADD with the DIVA interview, but same thing, can't totally diagnose that ADD while the depression is not yet managed. And then as results start coming in, Emily in the EMR starts to draft responses for the various labs and the screenings that are coming back. And then the advanced practice clinician on the team edits those and sends them out. We have our PAP visit. We do the things that need to be done in person, which is the immunizations and the actual PAP itself. At some point, she sends a rash picture because it didn't fit into any visit, but we're able to kind of pattern match that and get a differential diagnosis from Emily. Same thing, draft a response, so we handle that. Charlie is continuing to follow up on the chronic condition, so the depression, abdominal pain, and the blood pressure. And then at the follow-up visit with the doctor, she can really focus on the outstanding questions of the meds for weight loss, meds for perimenopause, any other questions, and actually physically look at the rash. So it's still a lot, but the pain points of 1990 or of 2025 are handled a lot more smoothly. And so let's dive into those 4 pillars and kind of talk about how are we handling those things. So my proposal here is that we're going to switch to a trusted multidisciplinary pyramidal team. We're going to have all of the wonderful professionals that we currently have, and then we're going to have advanced practice clinicians supervised by a doctor who's together are responsible for a much larger panel. Patients are going to hopefully trust the whole team so that they don't have that do or die relationship and dependence on just that single PCP. And then this is good actually for all the professionals too, because we can take vacation, we can take days off. We know that the patients are known and they're being handled and the care is good. So we can disconnect when we're not at work, which is good for burnout. We'll have defined kind of clinical protocols that keep all the lanes, somewhat clear, so we know what everyone is doing. And that leads to the personalized cookbook, which when I was in Chicago telling people about this, somebody said, oh yeah, I love cooking. Yeah, food is really important for health. And I was like, oh no, not that kind of cookbook. So although I used a picture here of a cookbook, basically the idea here is really just that basic care should be basic and should be straightforward. We don't necessarily need to argue about what exactly are the standard labs for hypertension or how often we should do them. I would propose that we can come to some agreements about things like annual physicals and annual wellness visits and how we want to do those things. And then we personalize things when we need to, when they get more complex, and also based on the patient's values and preferences. So in her case, she had basic stuff, which was the labs, the mental health outreach, the lifestyle education, but then she had personalization in that we dealt with the suicidal ideation. The ADD concern was not blown off, it was explored and it was kind of handled. Expectations were set so that she could understand how the healthcare system is working and what she's going to get out of it. And then the care was empathetic, both from Charlie, but also from the clinicians involved, because burden was being taken off of them and they had more bandwidth and time to make that human connection. And even what if, AI could prompt us to remember details about the patient? So I don't know if you guys do this, but the sticky note, right, where you're like, okay, ask in June about the granddaughter's graduation, and then you hope to remember to read that note when June comes around and the patient's back in front of you. We could be having a lot more personalization built in that would be very patient-centered. Then, of course, as well, care was a flow here. So obviously it wasn't forced into rigid time slots. She initiated it by talking to the chatbot. But there were a number of modalities. So we had video, we had texting, we sent My Health messages with pictures, we had the connected home BP cuff, and we had visits in clinic. I think that this takes burden off of each individual visit to be the one magic thing that gets every single thing done. Couple words about that. Not everything is about tech here. So the inbox. My thought here is that really messages, although it's not functioning this way right now, messages are totally valid, important care. It's asynchronous care, it's convenient for the patient, it's often convenient for us to answer at a different time, but that they need to be valued and they need to not be another thing that's just added on to that shaky foundation, that it needs to be a true part of care where there's time given for it and sort of resources. Not shown in the case, but what about if we had AI that actually analyzed those messages and said, 15% chance of ever resolving this via message. And then it would convert it to a visit, use Charlie to actually schedule that visit without extra effort and burden. And then, we can have the sort of prep from the messages and have a more efficient visit that happens rather than sort of, endless cycles of back and forth. And then also because, again, it's not all about tech, it's us too. I would propose that we also can get sharper and more efficient about how we communicate. In our messages, we can use simple language. We can define options, if this, then that. So for example, I was in clinic the other day and I was kind of looking at some messages in an inbox, and one provider kind of took a very complex x-ray report with all the jargon, cut and pasted it into a message and asked the MA to call the patient and read it. And the MA was like, can you translate this? Because she's not gonna understand this at all. And so the provider did kind of do that. And what I saw that as is the MA is trying to make a protocol of how we actually communicate, but without really any support or sort of, official structure around that. And so let's put that structure there so that we know how to best communicate with each other. And that we would say things not like a word cloud of blah, 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 that kind of comes off the top of our head sometimes when we're asked a clinical question, but really, again, lay out the next steps. And I think that in this as well, we have room to ask a little more of patients at times. Not every patient, not every time. There's barriers of health literacy and also just simply illness and various factors. But also I do think that we can treat adult patients like adults. We can have them step up their part of the partnership. They can come a little bit more prepared, perhaps not just my stomach hurts, like it's out of the blue, but actually with some sense of what's been done already, where they're at with it. Do the symptom questionnaires and have their own list of questions ready. Do your negotiation, of course, about what you're going to cover during that day. And hopefully start and end on time because we have a flow of care. So again, not everything has to fit within those rigid confines. I'm not going to get super into this, but of course, we need better behavior, and threats and violence are unacceptable. And I do think that that needs to be an important part of safeguarding our precious healthcare worker resources for the future. And so the last thing, supported by tech, so metrics and outcomes. Obviously, the tech that was highlighted here was Charlie and Emily, as well as smartphones and connected cuffs and texting and video. But even beyond this, we didn't construct the case this way, but saw tons of those vendors with predictive analytics about who's at most risk for readmission after discharge, who's at most risk for a CHF exacerbation. We could have things like, oh, pharmacy records are flagging us that patient didn't pick up their diuretic. Charlie or a nurse reaches out to the patient, starts to find out that yep, they're off their diuretic. Yes, they've been eating more salt. We jump on that to prevent that CHF exacerbation before the patient hits the ER. So that sort of thing, essentially kind of knowing where to direct our resources, and that physicians basically sort of in concert with the AI will be managing the health overall of the whole panel. This gets important when we talk about how to pay for it too, which shows up here in common objections. So as I've been sharing these ideas, I've certainly heard a lot of interest and also a lot of questions. And I thought if we have time, you might have to time check me, Anthony, here, but we can spin quickly through these. Quickly. Okay. What if it makes us stupid? All right, that's a big one. I don't think it's going to, because I think we're going to have to always maintain our clinical judgment. We're going to be having constant CME from this clinical decision support, but we're going to have to stay on our toes and stay ahead of it. What if it replaces doctors entirely? I don't think so. I think the human touch never goes out of style. I think this just helps us have more time for that connection. Doctors don't want to give up their visits. Yes, that's true in a lot of cases. However, I don't know that it's a luxury that we're going to have in the future, honestly, to just continue to do things like we did in 95 or even 2025 because of lack of knowledge workers, essentially. Patients just want to see their doctor. Well, some of them do. Some of them want that transactional, get me my care the way I want it. Some people never want to come in. And really, to meet our current standard of care, we need the whole team, not just one PCP. Docs don't want to supervise APCs because we weren't trained to do this. Again, I think that's maybe the case for some people, but it's probably a luxury that we can't afford, especially because everyone brings their unique strengths to the team, and the team will be stronger with all of us. Can we trust AI? That's not something that any of us can probably really control, but my feeling is that if we are going out ahead of this, that we have a better chance of being able to trust it than if, again, we sit back and wait and sort of see what happens. And then how will we pay for it? If I could wave my magic wand, I would put us probably in total cost of care contracts in which the money that we're going to save by preventing worse outcomes, not only that that's a value in and of itself, preventing bad outcomes for patients, helps fund this care redesign. And this does require, perhaps some different payment models and truly going more towards value-based care. Okay, in the interest of time, I'm going to spin very quickly through this. You guys are probably all familiar with direct primary care. It keeps coming up for me as I'm shopping this concept around, where folks are saying, yeah, but you know what? I just want to go back to basics and have more time with patients and just cut out the middleman and kind of have this one-to-one relationship. I think there's a place for that in the future. I just don't think it's scalable. I don't think it works to take care of the whole population, whereas I think Clinic of the Future can be personalized enough to cover the majority of people. I think there will probably always be doctors and patients who prefer to work in a more direct primary care setting, and there's probably going to be room for that, alongside. Okay, so last couple slides here. My hope is that this will allow us to be more Marcus or Marcia Welby rather than less. If we thoughtfully and responsibly kind of do this care redesign with more time and connection with patients and room to personalize care. How can we evolve? Maybe I'll just leave you guys with this because, again, we are a little bit running out of time, but we can do a lot of things on trust within our own teams, building team culture, starting discussion about clinical protocols and trying to come to some agreements about how we do the basic things in healthcare, leaving brain space for the harder things. Trying out the AI tools, if they go well, push for more, push for a roadmap into the future from your leaders as well. Talk about inbox management amongst ourselves, and also start to talk to our patients about maybe reframing some aspects of this partnership with the patients that we think are able to kind of engage in that and handle it. That's the end. What do you guys think? Thoughts, questions?
Sounds hard to change a system that fast.
Yeah.
I feel like COVID did it, but I've never seen it happen without crisis.
Yeah, I
Well
agree.
said.
I agree. COVID was a crisis equals opportunity moment, like for video visits and things like that.
But otherwise,
Absolutely.
it's like, let's buy this little piece of that thing.
Let's
buy
tweak this little
piece of
thing.
that.
Module.
Let's buy DAX.
I
Right.
think we're in a crisis.
Oh, we totally are.
Good
but
question.
I do think we're in a theoretical crisis, but not like the world. Our patients don't think that.
No, I think that's an interesting point. There's a gap there between.
Yeah.
Right.
Our patients are like, "There's no crisis. Why are you changing everything on me?"
Were you at the
Yeah.
Becker's
That's a really good point.
conference last week?
No, it was Total Health 2025 by Reuters. Yeah.
I was at a different conference last week.
Oh, cool. I want to hear about Becker's. I
It
thought
was
about that
all
one
A
too.
bunch of CEOs and CFOs at Becker's conference. And what was interesting listening, it wasn't as doom and gloom as I thought it would be,
Mm-hmm.
which was interesting. Like I was a little afraid going into it, like, oof, this could be pretty dark. But actually people held optimism and space for
I would agree. I saw that
productive
too.
solutions. But there was definitely a recognition that the leaders in the near future and in the long future are gonna have a lot of partnerships, and their timed execution is gonna be much, much shorter. We're gonna have to have a
Fascinating.
portfolio of solutions that work synergistically. It can't be commoditization, I think is a great concern, and I totally agree with that, like, there's a risk there. But on the other hand, you can't necessarily assume that one solution is gonna answer all of the problems that we have. So it'll be an interesting mix. But I think we do have to get to that space of being like, no, this is now, this is here, we gotta change, and we gotta figure out how to exchange that. And we have to design, as you're pointing out, how do we want it to work? How should it work?
Right.
Everybody in this room is experts in what you do.
Yeah.
You might have to change a little, might have to all collectively say, what could we do differently? And that's hard, that is change. But at the same time, I love the suggestions you're making here, Alex.
Thank you. Thank you. Perspective too. And I would say, yeah, at Total Health 25, I was surprised. The big themes were trust, empathy, human touch, and value-based care. And that was really interesting. And I think to your point, yes, we perceive the crisis more than they do perhaps. And I think they'll probably start to perceive it when all the PCPs are quitting. And I'm hoping that we act before that happens, because that will be really disruptive for all of us and for them. And so, yeah, maybe some communication and change management, strategies for how we bring patients along with where our thinking is going. That's a really good point.
Not even a question of the PCPs quitting, we're just not training enough physicians at all.
Yeah.
And enough physician PCPs if you really want even
Right.
this model with APCs.
Right.
I don't know, I'm kind of glad I'll probably retire in the next 10 years. Because I really like my longevity with patients, and
Yeah.
I look at my precepting role,
Mm-hmm.
and while the patients may feel that they know me well
Mm-hmm.
because they've seen me, I don't know them well.
Right. It's different
Unless
than being
I've
in those
been-
visits.
But
Yeah.
versus my own patients.
Right.
Yeah.
No, that's
You
true.
know, I just don't know them as well.
It's rewarding, right?
The
Exactly.
AI thing doing so much also is so tricky because sometimes you feel so responsible for knowing everything about the patient
Mhm.
because the ER exists. So if the ER exists, you're supposed to know what happened, and
Mm,
and it's sort of like if all this AI stuff and all this happened behind the scenes, it's like the paradigm, like the status quo shift of not looking at all that would be hard.
yeah.
Yeah.
For sure.
Yeah.
Maybe I'd still be doing the same.
Right.
Yeah.
Well, and there would probably have to be some hybrid approach, right? Because again, we can't trust it entirely. I don't want to imply that somehow like everything it says is 100% true. I think we know that from Copilot or, ChatGPT or whatever people use. So yeah, there would be some need to like sort of do your own checking and whatnot. I do also think that the idea that you have to know everything about the patient. Thank you guys. Thanks
Thank
for
you so
coming.
much.
Yeah,
It's
yeah.
fascinating.
Awesome to see you. Is flawed. And I feel that too, and that's why I would have these crazy sticky notes that would be a mix of like, oh, I would get a lab result, and then I'm going to put it on the sticky note so it can be top of mind when I see the person next, along with the granddaughter's graduation thing, and it's crazy, and the patients expect that because they think they're your only patient, literally, and so I do think that we can reframe that and draw back the curtain a tiny bit and be like, I have one friend who truly does have short-term memory challenges, who's a physician I went to med school with, and she's like, I just tell the patient I don't remember anything. Like she just sets this basic, baseline of like, didn't I tell you about my neck pain? I don't know, you probably did, but I don't remember.
That's called being an ER doc.
Yeah. I like it. Yeah,
you
exactly.
remember me
And
from last
I
week?
felt
That's right.
uncomfortable doing that because I didn't want to admit, oh my gosh, I don't remember, but
Yeah.
it's a kind of an impossible expectation. And if we can get these prompts and assists from our little helper, is that a bad thing?
What about I'm gonna use, so what about the somatizing patient? Like, that's where I feel like my talent is really good with the longevity of knowing this patient and knowing to do enough but not too much.
Right.
And how do you envision AI working with that? Because I know when my patient sees one of my partners, they're more likely to
They
get
get drawn in.
testing
Yeah,
or something
for
done
sure.
than when I see them.
Yes, I think that is an amazing question, and it sort of ties into my point about how our doctor's going to justify our existence in the future. Because there are people out there that are kind of like, I actually spoke to a gentleman who was like, we're not going to really need primary care because everyone's just going to talk to AI on their phones, and they're going to decide between the blood pressure med classes based on their preferences and side effects and whatever. And I was a little bit like, whoa, I think I'm thinking boldly, but like you're 4 steps ahead of me, and I'm not sure I love where you're going with that exactly. But it gets at this idea that there are people out there who really think that like the primary care doctor is going to be an anachronism. I don't think so, because I think the judgment and the relationship is always going to be the key thing. And I think that that's how you.
And exam.
Yeah.
See, that's what
Yeah.
separates us from maybe radiology. Like,
Right.
we do an exam
We do.
that can change. Like, I've even been writing out orders for a patient, and then I do an exam, and I'm like,
You're like,
oh, I was wrong.
Same.
I was wrong. That is
Exactly.
the wrong. I was heading down the wrong
Right.
pathway, and now I'm concerned about this.
Exactly. Which is why I think it shouldn't be the doctor. It should give you ideas, and your judgment should always be that final, deciding factor. And I think that's how we're gonna prove our worth and, continue to sort of be, viable in the future ecosystem.
It's those questions you ask while you're doing the exam too, while you're actually touching the person. You find out so much in that moment.
Yeah.
You ask just that one subtle question.
Or the distraction,
Or the-
yeah.
yeah.
Seems like certain things can be automated,
Mhm.
like ordering the colonoscopy should not be in our,
Exactly.
Agreed.
Yeah.
should
Exactly.
not be something I have to remember.
No.
Or the flu shot, or the
Mhm.
COVID vaccine,
Mhm.
or anything else that's sort of automated that can be, like somebody else, if there's a question about should I get this shot, like by all means, ask me that and we
Right.
can talk about it.
Mhm.
But it shouldn't be based on my memory
Right.
of seeing 8 patients. Did you get a flu shot and a COVID on every one of them, or ask about it?
Yeah.
Well, maybe I remember 6 times out of the 8. That
Exactly.
means 2 people got missed just because, they talked to me about something else
Yep.
and they ran out of time.
Yep.
So things like that, if we can automate and get it off the physician's
Yep.
plate, would be great.
And the brain space that you're using to remember that too is running down your energy and maybe taking away from a higher level conversation that only you can have with the patient, So, and Annie, you were going to say something.
I was just like, I guess in terms of feedback on this presentation,
Yeah.
I guess if you're going to be giving this to a lot of high-level people that are making decisions about where this stuff goes, I think there needs to be some emphasis on what our value is and what
Yeah.
we'd be doing. Like, I feel like we
Right.
skipped over the part where the physician actually does anything
Mm.
other than be personable. And I
Yeah.
think they could easily say, well, anyone can be personable. It doesn't have to be
Good point.
somebody
Okay.
with a
Including
doctoral
AI,
degree.
right?
Yeah.
Yeah. And I don't think that's true. I
Mm.
think there is still a lot, including the physical exam, that we really bring to this. That's more than just, being friendly with the person
Yeah.
and understanding how to talk to them. That
Yeah.
I think is really
It's
key.
That's a great point.
It's
Thank
the-
you for that.
It's the 50-year-old
Absolutely.
patient of mine who I saw last week for physical, and we talked about a lot of issues, and I talked to her about her drinking, and she goes, "Oh yeah, I've cut way back because you told me last time that I was,
Yeah.
and it's that long
Oh,
relationship. And she
rewarding.
wasn't
It
drinking a
changes
ton,
lives.
but
Right.
we know
She
any
just
amount of
cut back.
alcohol
That's
is
great.
not considered safe.
Mhm.
And I was like, it's the years of her trusting me that led her to cut back when I said, you really shouldn't be drinking that much.
Mhm.
But
That's
that is
fantastic.
where I think the tools can help you, like, gosh, last time you talked about this, you may want to follow up on that conversation at the next
Right.
visit. Or
Exactly.
this patient has lost 5 pounds, maybe a conversation about food insecurity because they also lost their job, and subtle things
Yes.
patterns that may be hard for anybody to comb through the whole chart and
That's right.
recognize those things.
Mhm.
Maybe there's ways to augment that that thing you bring to the relationship
Yeah.
by giving you some factual
Yeah.
clues and breadcrumbs to be like, that is an interesting pattern. Let's delve into that a little bit.
Mhm. That's a great point. You answered that better than I could have.
I have a quick point about this idea that we have all of this personal data that would be fed into the model. And right now it's anonymized, right? If you're using an ambient scribe, you're not using their full name and date of birth, and it's all like, here's Joe. He's a guy, and here's his medical history. So we're going to have patients who are buying in and saying, I'm going to feed all of my data into the chart. The AI is going to be scrubbing the entirety of all of these EHR systems.
Yeah.
That's kind of a scary thought. And like the number of people that would need to buy into that before we could even move towards this direction. And I know that there's unknowns that we might commit and then regret it, or we might commit and say this is the best thing for humanity. I don't know. But I think that that's a big question mark in my mind as I kind of see how this would integrate.
So let me learn a little bit more about that. So patients are already signing terms and conditions, right, when they come, and they're basically saying, yep, you can disclose stuff to insurance or for billing purposes and all these different things. And then we already have all this stuff that we're putting into the EMR. I think that without us necessarily, so far as I've seen, agreeing or disagreeing with it as physicians, the AI companies are moving to integrate all this other data. It's claims data. It's, I believe, pharmacy records, like I was kind of mentioning, like you're going to check on like whether things have been filled or not, which they already do that now in other ways, like for the like statin adherence measures and things like
and then
that.
it comes to us.
Yeah.
to
And then it
look
comes to
at.
us to
Right.
like
What do I do with
Right.
this?
yell
I
at
don't
them
have
to
time
be
to call them.
Right.
on the statin. Yeah, exactly.
This is not an opt-in, it's an
so
opt-out.
It's an opt-out. I
Yeah.
actually, I foresee that only I don't know. I would kind of think that only the savviest patients will realize what's going on there.
Yeah.
And if they opt out, then it's going to be like, oh, I'm not signing the T's and C's. You can't be seen here at the clinic. Now, I'm not saying this is good. I think that maybe there'll be a debate in sort of some esoteric circles about like how's our data being used. But I think most people are so willing to just sign their data away for any old thing and convenience and some app that they download
to
and
get
it
that
gives-
coupon.
Yeah, to get that coupon. Yeah, exactly. You know, so it's a good point.
Every time you
The
ask
amount-
them to do DAX Copilot, like, can they listen to your our conversation?
Mm-hmm.
And it's going to be recorded, and you're like, yeah,
Yeah. Do you get patients pushing back at all, or
not at all.
right?
Oh, I do.
Occasionally. Yeah.
Really?
We have
I've had
Okay.
0 so far.
Even young ones.
Huh.
Oh, yeah.
And what do they say? Just that's creepy, or I don't
One of them
know.
just said hard no.
Yeah, there's a lot of
They sell it.
I have a patient who's an OBGYN, he melted down about AI. I was just like, dude, you need to contain yourself.
Oh, wow.
I've been finding new ways to say it that I think are a little less scary, I guess. But
Interesting.
I don't start with AI.
Gotcha.
Exactly.
Yeah. Thank you. Thanks
Um,
for yeah.
Anyway, yeah.
Cool.
I mean,
Thank you
I
guys
guess
so much. Thank you.